Good day, everybody. My name is Charles Dela Cruz. I'm here at Yale University School of Medicine, New Haven, Connecticut, in the section of Pulmonary Critical Care and Sleep Medicine in the Department of Internal Medicine. I'm also the director for the Center for Pulmonary Infection Research and Treatment, CPIRT. I'd like to thank the organizers of this international course on respiratory infection, Dr. Carlos Luna and his colleagues. Thank you for the invitation. And today I'd like to share you some of the updates with regards to COVID-19 and treatment. I have no financial disclosures. To begin, I'd like to talk about the different stages of COVID-19 that has been described so far. There's an early phase represented by viral replication or viral response, characterized by some of the clinical symptoms of fever, chills, cough, and symptoms of diarrhea, headaches, and nausea. Some patients develop a pulmonary phase where they have symptoms of shortness of breath and oxygen desaturation with findings in the chest imaging. These involve some of the early host inflammatory response against the infection. And then for some unfortunate few patients that develop progressive disease, ARDS, shock, cardiac failure, and multi-organ failure is represented by a phase where there's hyperinflammatory response. And this goes along sometimes with the inflammatory markers that are elevated, such as CRP, IL-6, D-dimers, and ferritin. And I have this different phases to show you potentially where antivirals and immune modulators could be used against this infection. So the World Health Organization have developed an ordinal scale to describe different stages of clinical disease. And then World Health Organization have a scoring system from 0 to 8, from patients who are uninfected to patients who are outpatient, ambulatory, to hospitalized patients requiring oxygen, to patients who are hospitalized requiring more support, including mechanical ventilation and other organ supports like dialysis or ECMO. And these are important as some trials use these ordinal scales to determine their efficacy. And so in some of these trials, they use different versions of this ordinal scale system that people should pay attention to. In addition, it's important also to see the life cycle of SARS-CoV-2, which is the virus that causes COVID-19. Here you can see the different treatments and targets against COVID-19 based on the life cycle of this virus. For example, the virus, have to have an entry into the cell requiring the ACE2 receptor as well as a TMPRSS2, where camostat potentially can inhibit and prevent viral cell entry. The virus, once gets inside, through membrane fusion or endocytosis, which is a target for hydroxychloroquine, for example, these viruses have an uncoating process where RNAs can release, forms polypeptides to make non-structural proteins, and with the use of RNA-dependent RNA polymerase is important for the viral life cycle to make new viral RNA, and antivirals such as lopinavir or remdesivir target some of these pathways as mentioned here. Once structural proteins are made, and these are sort of viral structural proteins are needed to make new viruses, assembly takes place, exocytosis for the release of these new virions for dissemination. Here also outside the cell, you can see what's released by immune cells, such as the macrophages, or cytokines such as interleukin-16, which has been target for some of these therapeutics, such as tocilizumab or sirolimus, that binds to some of these IL-6 receptor or inhibited signaling. So drugs have been used and repurposed for COVID-19. Early days, lopinavir has been used given its activity against coronavirus. However, early studies have shown that there were no differences in clinical improvement or mortality, as shown by the paper by Cow in New England Journal earlier on. Here's a list of all these different antivirals. In red, I highlight some of these that are actively pursued in clinical trials. Camostat, for example, is a serine protease inhibitor that binds to one of these viral entry molecules, TMPRSS2. There are antiparasitic drugs, as listed here, and antibacterial, which currently have not had any clinical trials to show any efficacy so far. And So remdesivir has been used and heard a lot in the press. It's a nucleoside analog against the viral RNA-dependent RNA polymerase, and it inhibits viral replication. One of the first studies through the National Institute of Health, the ACT-1 study, which is a double-blind placebo-controlled trial for hospitalized patients over many sites, initially looked at patients hospitalized for COVID-19. Here you can see that most of these patients, a median time from symptom onset to randomization were 9 days. It targets, as I mentioned, this RNA polymerase-dependent polymerase. And most of these patients enrolled have severe disease, with ordinal scales of 5, 6, and 7, where at least in this study, ordinal scale of 5 are patients requiring supplemental oxygen. So most of these are severe cases. And what they found was in patients overall compared to placebo, remdesivir patients had a shorter median time to recovery of 11 days compared to 15 days, which is highly significant given the p-value with the rate ratio of 1.32. Mortality, there's a trend towards decreased mortality in patients on remdesivir compared to placebo. What's interesting in this study, most of the patients who benefited from the remdesivir happens to be with ordinal scale 5, which is patients on oxygen. Less of an effect, patients were more severe at 6 or 7 ordinal scale, suggested that treatment early with remdesivir might be more beneficial. There are studies right now ongoing to look at remdesivir for later phases to see its efficacy in the more severe cases setting. And so currently it's our standard of care to have remdesivir as part of the regimen for hospitalized patients, especially for those who are on oxygen. So hydroxychloroquine received a lot of press. It's a controversial drug. It's an antimalarial agent, initially with a lot of in vitro activity against other coronaviruses. The hydroxychloroquine part is better tolerated and actually has more potency, again, in vitro. Early studies, as listed here, small studies, suggest a possible sort of clinical benefit of using hydroxychloroquine in patients with COVID-19. There's an initial study, actually a quite small study, that was also controversial, actually not well done, that suggests that potentially having azithromycin in addition to hydroxychloroquine could be beneficial. So with time and with more large-scale studies and randomized placebo-controlled trials, has shown really no significant role or benefit of hydroxychloroquine for the treatment of COVID-19 for patients who are hospitalized. The Tang study in China suggests that there's no virologic conversion or symptom resolution. The study done in Brazil compared to high dose versus low dose of hydroxychloroquine actually showed that increased mortality for individuals who receive the high dose regimen with hydroxychloroquine, and there are actually more side effects with QTc prolongation. Here in the US, the ORCID-PATO trial was actually stopped early after finding no additional benefit compared to placebo, and then the recovery trial in the UK showed no benefit in mortality with a large number of patients studied. So I think currently, it's not recommended for the use of hydroxychloroquine at all for COVID-19. There are also studies suggesting that hydroxychloroquine with azithromycin is also not beneficial, but in fact probably have more side effects. So convalescent plasma is also being used, historically been used for viral infections with some good effects. It's through apheresis of survivors for their acquired neutralizing antibodies for positive immunity. Some of the studies use patients who are asymptomatic after their infection for 10 days. Some of them look at specific ELISA. Through ELISA, their antibody titers and neutralizing antibody titers. These are usually screened for not having other viruses. In this one small study, in the severe patient population, they show some normalization of temperature, SOFA score, resolution of ARDS. So this is a very small study early on convalescent plasma. Later study using sort of more open label or early safety studies suggest that initially clinical improvement of 28 days actually did not find any difference between convalescent plasma and control. And then this one study from China, this Lee study, looking at mortality and time to discharge. However, it was also not statistically significant. What they did find in this study in the severe disease group, actually shorter time to clinical improvement and higher rates of clinical improvement at week 28. And so it was kind of promising. This study actually was cut short in China because at the time they did not have enough new cases, and then was published later in JAMA. There's an early safety study, the Joyner study in the United States, looking at 5,000 patients on convalescent plasma. Some of the side effects noted were acute lung injury, overload, and allergic reactions. In fact, it was deemed to be safe, quite safe. Only 2 of these severe adverse reactions are related to the transfusion. So we're still waiting for a big randomized control study for convalescent plasma. The closest, I guess, information is actually a retrospective propensity match study that was recently published in Nature Medicine. They matched the patient population with or without convalescent plasma, and they actually showed O2 requirement worsening was a lot less in convalescent plasma compared to control, and then the patient actually had improved survival that is statistically significant in this group. So promising, but I think we're still waiting for the clinical trials, randomized control trials to be completed and published. And so this is very dependent on different sites, their ability to have convalescent plasma available. So it's only recommended in a clinical trial setting currently. So after the antivirals, you think about the immunomodulators. I mentioned already that with COVID-19, there's some element of hyperimmune response that could be pathologic. And here are some lists of these immunomodulators. Certainly, I think there's a lot longer lists for immunomodulators that are being tried in different clinical trials. Going to talk a little bit about IL-6 later on. There's IL-1 inhibitor, a JAK inhibitor, baricitinib, for example, monoclonal antibody against some complement, the eculizumab, and then steroids. And so talk about a little about steroids. So steroids in our early experience with coronavirus and MERS, for example, actually showed there was increased viral time of clearance and worse outcome. And so people are really hesitant initially with SARS-CoV-2 to use steroids. And so what's interesting is some early studies with SARS-CoV-2 actually showed some beneficial improvement with the methylprednisolone here's trial in ARDS compared to no steroid. And so this was one of the first hint that potentially maybe SARS-CoV-2 is a little different from the other coronaviruses, and that maybe steroids could have a potential benefit in these patient population. So then it wasn't until several months ago, this recovery trial based in the UK, which essentially is a platform-based clinical trial looking at different therapeutic agent. In this case, they were studying oral versus IV dexamethasone, 6 milligrams daily for up to 10 days versus the standard of care with no dexamethasone. And they were interested in mortality, median duration of, and as well as some other secondary outcomes. And so in this study, the median duration of treatment with dexamethasone around 7 days, and you can see there's a wide range from 3 to 10. And this is a large study, 2,000 patients on dexamethasone, 4,000 patients on control. And they actually saw lower 28-day mortality on the patient population that received dexamethasone. Here you can see the different graphs, all participants in the dexamethasone group in red, and basic population in B, and then oxygen only. There is really no effect of dexamethasone on patient or not on oxygen. In fact, you can see that patient not on oxygen given dexamethasone, there's actually increased mortality. And so, so this trial sort of puts corticosteroids, specifically dexamethasone on the map for the treatment of COVID-19, specifically for patients with more severe disease requiring oxygen. And that certainly has, in addition to remdesivir, has become a standard of care as well in many institutions. So I mentioned a little bit about tocilizumab. It's an antibody against the IL-6 receptor. We know that some of the viral pneumonias in the past, including COVID-19, has elevated interleukin-6. This tocilizumab, for example, have been used for rheumatoid arthritis and CAR T-cell therapy therapies with some success, and people were extrapolating some of these to maybe COVID-19. Early studies have suggested in smaller numbers of patients using tocilizumab, clinical improvement of resolution of symptoms and imaging. And many places, it became one of the treatment algorithm drug. Tocilizumab could potentially also have antithrombotic effect. And so this is where it works on, which is the secretion from some of the immune cells. The phase 3 Covecta trial was reported a few months ago through a press release suggesting that their primary endpoint was not met, tocilizumab compared to placebo, suggesting that there's no, at least in this trial, clinical efficacy with regards to clinical status, 28 mortality, no difference, ventilator-free days, no statistical difference. The only sort of possible difference is that the time to hospital discharge was shorter in the patient with tocilizumab, and so, but this was not their main primary endpoint. And so I think there's a lot of reconsideration about the use of anti-IL-6, fairly expensive. I think additional trials are underway to see whether this is useful or not. And so I think this is only reserved for clinical trial purposes. So in summary, COVID-19 treatment, there's currently no approved drug for COVID-19. I think to date, some of the trials support the use, at least in a hospitalized patient, remdesivir as an antiviral. It showed decreased time to improvement, specifically in the moderate to severe cases. In the dexamethasone group, as an immune modulator, you saw the data that it's only mostly useful for patients who are on oxygen or more. The convalescent plasma is certainly potentially safe. Preliminary data finding shows survival benefits when given early, and maybe requiring high immunoglobulin from the plasma donor content. And so some of the studies currently are actually measuring the donor plasma for antibody titers. Hydroxychloroquine plus or minus azithromycin, there's certainly no benefit and potentially harmful. Potentially there's combination use for antivirals and immune-modulating drugs. For example, combination remdesivir, dexamethasone may be used in future. It's actually being used in many algorithms already for some of these patients. So what I haven't discussed are therapeutic options for mild disease for outpatient settings, and certainly there's some trials going on either through antibodies or certain specific antivirals. Those are much needed. In addition, there's a lot of discussion about preventative measures to tackle and curb COVID-19 pandemic. And I think what's needed also is all these different vaccine strategies and efforts that are being done through clinical trials, which I have not discussed today. So thank you for your time, and I take any questions. Thank you.
Thank you very much for the introduction. I would like to start acknowledging both the organizer of the Curso Internacional de Infección Respiratoria 2020 and the chairman of this session for giving me this opportunity to provide a few insights on the use of ECMO in COVID-19. In the next 10-15 minutes, we will discuss, based on the currently available evidence, should we use ECMO in COVID-19 patient? The evidence is limited, but there are a few important results from observational study that could use to infer in our indication for ECMO use. A few insights also on methodological insights on ECMO calculation, patient management. We will conclude on an important call for inclusive research in this field in order to learn and understand more on this technology in COVID-19. When you look at the COVID-19 pandemic, it's absolutely astonishing the situation we are at this moment. These are precedented times. There is nothing that can be compared with previous major outbreak or pandemic. Even the H1N1 was not comparable to the COVID-19 pandemic in terms of number of patients and in terms of upsurge of need of clinical services. Indeed, when you look at the Hopkins map, today there are more than 34 million people who have been diagnosed with COVID-19, and death associated with COVID-19 has reached more than 1 million people, and it's likely is these figures are underestimated and based on the testing for COVID-19. So in this grim situation, in this context, should we use ECMO, which is a very expensive, very sophisticated strategy in order to support patients on severe acute hypoxemic respiratory failure, or should we rely just on invasive mechanical ventilation to support this patient? When we try to address this question, there are many factors that we should take into account. In particular, who are the patients who benefit most of the technology? What about long-term outcomes? We do know from observational study, from the latest studies, for instance, mortality up to 90%, but we do not have any idea of long-term outcomes of this patient. What about cost-to-benefit ratio, particularly in countries with limited resources for healthcare? And what about the new therapeutic option? The recovery trial or the remdesivir trial gave us a lot of important results that could play an important role in our decision to use ECMO. And which center should provide ECMO? Should we establish a new center, or should we stay with the ECMO centers that been pre-COVID-19 era and do not create other ECMO center? Or I think that the most crucial question is about future studies and the possibility to design randomized clinical trial to comprehensively assess the efficacy and benefits of ECMO in COVID-19. This is challenging, maybe impossible, but it's worthy to be discussed. When you look at the initial manuscript, for instance, the manuscript by Henry that pulled data from several early studies on COVID-19 patients, many of those from China. When you look at the mortality rate, in many of these studies, there was zero survivors. And in the best case scenario, they reach a survival of 16%. So many experts in this field became highly concerned on the use of ECMO. And indeed, the forest plot showed almost a two-fold increase in death with the use of ECMO. In another study from Wuhan, in which for the first time compare invasive mechanical ventilation versus invasive mechanical ventilation plus ECMO, the results were not dissimilar than the previous study. Indeed, they found an outcome of mortality rate of 60%, irrespective of the use of ECMO, and just slightly lower, 57% in the group with ECMO and invasive mechanical ventilation. So after this study, many society, even the Health Society, called for the need for further investigation on the use of ECMO. Otherwise, ECMO would have been futile, fully futile in the COVID-19 pandemic. And one of the biggest studies that came out after this call was the study from the Pitié-Salpêtrière hospital. This is the same hospital. The first author was Matthew Smith and Alan Combs, and this is the same hospital that published a few years back the Eolia study. It's a study just in 83 patients. The age of the population is slightly younger than 49. The time from intubation to ECMO was 4 days, so quite rapidly they went on ECMO. And when you look at the ventilatory parameters before the commencement of ECMO, these were highly severe, highly difficult to manage patient from a ventilatory standpoint. Indeed, they had a driving pressure of 18, irrespective of a PEEP of 14, and a mechanical power of 24.7. And when you look at the severity of the hypoxemia, PO2 FiO2 was 60. That was very similar to the Eolia study. And they use every potential rescue therapy known in order to avoid ECMO. Indeed, they use a neuromuscular blockade and prone position up to 96% of this patient. Then, when they started ECMO, the configuration, the most frequent configuration was always femoral jugular veno-venous. Just in 1% was veno-arterial. They use in up to 69% a very large bore drainage cannula, up to 29 French. And when you look at the results on after ECMO in terms of ventilation parameters, they were able to reduce the plateau pressure from 32 to 27, the driving pressure from 18 to 12, and the mechanical power by 75%. And during the study, in the majority of these patients, they use heparin on continuous infusion, but they increase the target PTT for PTT range. Indeed, they aim to an PTT range of 60-75 or anti-XA activity of 0.305, which was higher than the Eolia study, because they learn from early cases or from other reports that the thrombotic risk for this population was very high. In terms of the mortality, these were the mortality figures that provide the French collaborator, French investigator, was absolutely different than the early report. They provided an estimated 31% probability of death after 60 days. That in terms of estimation didn't change that much at 90 days. And as said, these were completely different results than earlier report. Of course, we should look into the result from a critical standpoint. In particular, this was an observational study. There was no comparison with the patient, similar patient who were managed on invasive mechanical ventilation. These were younger patients, younger than 50 in comparison with the reported case series previously. This was a monocenter study from one of the best hospital in the world for ECMO support. So it's uncertain the reproducibility of this data in other ECMO centers. Only 14% received corticosteroids. This is important because this was a study in the pre-recovery area. And another concern about this study was the rate of pulmonary embolism that occurred in up to 90% of these patients. In another important paper worth to mention from Rush University in Chicago, and I would like to emphasize this is another center that one of the best center worldwide for ECMO support. They study just 40 patients younger than 50, again with a plateau pressure before ECMO 32 and PO2 FiO2 lower than 70, and they use a configuration that was completely different. Indeed, they use a single access cannula with the drainage from the right atrium and output into the pulmonary artery. They needed a fluoroscopy in order to place this cannula, and echocardiography was used to corroborate correct positioning. They use several other strategies in order to improve patient outcome, like inhaled pulmonary vasodilator therapy, anticoagulation with bivalirudin rather than heparin, and PTT goal of 45-70, and oral quetiapine and all the other sedatives removed in order to facilitate early mobilization of this patient. So several different approach in comparison with the previous study. And after, as you can see here, the ECMO was provided for 30 days, and the mortality rate that they published was absolutely stunning, uncomparable with previous report. Indeed, they report an overall mortality of just 15%. In September, late September, the latest and the largest study on ECMO in COVID-19 was published by the ELSO registry. This is a registry that was already running before COVID-19, so they were able in a quite short period of time to enroll more than 1,000 patients. The majority of these patients were on veno-venous ECMO. Then there was 4% on veno-arterial and other configuration, other setting in 0.9, less than 1%. And they wanted to provide a generalizable estimate of ECMO mortality. And this was made through enrollment in more than in 200 hospitals in 36 countries, not just a monocenter study. And the age was similar to previous study, younger than 50, and BMI of 31. When you look at the mortality of rate of this population, they were able to have a mortality lower than 40% up to 90 days from ECMO initiation. There was some complication. The most frequent complication was central nervous system hemorrhage and lung failure, membranous lung failure in 8%. That strongly emphasize coagulopathy or thrombotic risk in this population, but still the estimate cumulative incidence of in-hospital mortality in this population was 37.4. And these are not different figures in comparison with the Eolia study that reported 35%. They were able also to find other important risk factors for associated with mortality: age, immunosuppression, chronic respiratory disease, pre-ECMO cardiac arrest, acute kidney injury, and the configuration of venous arterial versus venous venous. So based on this evidence, this currently evidence, and several guidelines have been provided, particularly ELSO, which is the worldwide organization for ECMO support, provided some guidance initially in March, and then later on more comprehensive and detailed guidelines. So looking at in the next few slides about the recommendation from ELSO, ELSO strongly highlighted the importance of provide ECMO in established ECMO center. ECMO is not a technology that can be learned just in a few months, so creating new ECMO center would be deleterious rather than beneficial for this patient. And it's absolutely important to have a central coordination at the country level or regional level in order to understand how overwhelm could become the system that provides ECMO. Indeed, they provided 4 tiers of contingency capacity or ECMO capacity that started from conventional capacity up to crisis capacity. And this is important to be continuously updated in order to not create a situation in the healthcare system already overwhelmed that can become life-threatening for patients who are on ECMO. The indication, another strong recommendation by the ELSO committee was indication. These are the indications that were also in pre-ECMO, pre-COVID-19 era, when there is a PO2 lower than 60 for more than 6 hours or lower than 50 for more than 3 hours. This is a good indication for ECMO, or there is a severe hypercapnia with pH not corrected for more than 6 hours. As I said before, we are in unprecedented times, so indication and particularly contraindication cannot be, rule and regulation could not be banded for COVID-19 patients because the healthcare system worldwide are already almost at capacity. In terms of the configuration, what they suggest is a VV ECMO with a large multi-stage drainage cannula, large cannula in order to avoid the insertion of an additional cannula later on, a single-stage return cannula, and the configuration mostly recommended is the femoral internal jugular. they discourage the use of dual lumen cannula, and this is because they are more difficult to be inserted. The maintenance is more difficult, and this could be detrimental in settings overwhelmed by many patients. The only exception, and this was not mentioned by Elsa, but we learned from the JAMA paper, is the use of single access dual lumen right atrium to pulmonary artery cannula, and this assuming that there is the expertise to use this cannula. And for the VA ECMO, femoral configuration and a distal limb perfusion catheter should be used in order to avoid critical ischemia of one of the legs. As for the general management, these are recommendations that are not that dissimilar from patient on ECMO for other etiologies. Lung protective mechanical ventilation, use of therapeutics at this stage, of course, remdesivir and corticosteroids should be considered. Early enteral nutrition, ECMO monitoring, early mobilization, and in center with expertise, the extubation could be considered during ECMO. And for the hematological recommendation, hemoglobin transfusion should be provided for to achieve hemoglobin greater than 7 or 8, platelet greater than 50,000, and fibrinogen greater than 100. But in terms of anticoagulation, they didn't provide detailed information. And what we learned from previous publication, for instance, the French approach was use of heparin, but with higher range of APTT. And the Russian university is something that should be considered and should be investigated further, use of direct thrombin inhibitors rather than heparin. In conclusion, in summary, the take-home messages: ECMO has been associated with high mortality in early report, and this has not been confirmed with in later publication. ECMO could be provided for COVID-19 but for COVID-19 patient, yet it should be provided with responsibility and in selected patient and just experienced centers. Otherwise, in overwhelmed healthcare system, ECMO could be futile if many of these regulations are banned. There are inadequate data to determine the efficacy and safety of ECMO, particularly the long-term efficacy and safety of ECMO. So it's important to further investigate in this field. And in this context, in just a few slides, I would like to introduce the COVID-19 Critical Care Consortium incorporating ECMO card observational study. This is a study that we designed in late January. I'm honored to be one of the principal investigator with Jackie Swen, John Fraser, Heidi Dalton, Adrian Burnett from Queensland. And these are the number of the number of countries that are collaborating with this study, and to date we have 53 countries collaborating, 209 recruiting centers, and almost 3,000 enrolled patients. And the level of details, the level of inclusiveness that is obtained from this study is uncomparable with previous observational study. Is not just about the acute study, but is also about long-term and other sub-study. Indeed, we are looking at neurological, cardiac, and coagulation disorder or acute kidney injury effect of COVID-19 and long-term effect as well. So if you want to join, please send an email either to me or ecmocard@health.qld.gov.au, and together we can improve knowledge in this field. Thank you very much for your attention.
Good afternoon. To start, I would like to thank the organizers for the opportunity to be with you today and to share some data about the relationship between VAP and COVID-19. Here are my conflicts of interest. This is the EPIC-3 study that was published this year in JAMA. It was an observational 24-hour point prevalence study, the largest epidemiologic study on infection in the ICU. There was a large number of centers all around the world, coming from 88 countries. More than 15,000 patients hospitalized in the ICU for more than 24 hours were included, and 54% among them had at least one episode of suspected or confirmed infection. As you can see, ICU-acquired infection represented 22% of all infections. Hospital-acquired infection represented 35%, and community-acquired infection was diagnosed in 43% of study patients. The most common site of infection was respiratory tract, with 60% of patients with infection coming from the respiratory tract. And in a multi-level analysis, ICU-acquired infection was independently associated with higher risk for mortality, with an odds ratio of 1.32. This is another large epidemiologic study, the TAVEM study, in which were included almost 3,000 patients receiving invasive mechanical ventilation for more than 48 hours. And the incidence of ventilator-associated tracheobronchitis, VAT, was 11.4%. The incidence of VAP was 13.2%. As you can see, both infections were associated with increased duration of mechanical ventilation and ICU stay as compared to patients with no infection, but only VAP was significantly associated with increased mortality, with a mortality rate of 40% as compared to 29% in VAT group and 30% in patients with no infection. So what about the relationship between VAP and COVID-19? There are some factors suggesting that the infection with SARS-CoV-2 could be associated with lower risk for VAP, such as improved hand hygiene, less altered innate immunity, and the altered gut microbiota. However, on the other hand, there are some factors suggesting that infection with SARS-CoV-2 could be associated with higher risk for VAP, especially the prolonged ICU stay and MV duration, but also the high incidence of ARDS and the common use of immune suppressive agents. To the best of my knowledge, there is no published study to date that specifically evaluated the relationship between SARS-CoV-2 infection and VAP. This is one of the first cohorts that were published on COVID-19 patients, and in this cohort we can see that the incidence of secondary infection was quite low, 10% of study patients. It was higher in ICU patients, with 31% of patients who developed a secondary infection, and there was no infection in patients outside the ICU. Another cohort coming from China, in which the incidence of hospital-acquired pneumonia was also quite low, around 11%. and the incidence of this infection was lower in non-survivors than in survivors, 6% versus 20%, probably because the duration of exposure to risk was lower in the non-survivors group. Another cohort, a large one, 1,000 patient hospitalized in the ICU in New York City, in which the incidence of VAP was around 25%. However, all these studies have several limitations that should be outlined. There was no clear definition for VAP in these studies. We don't know whether or not there was a microbiological confirmation of VAP. In addition, the number of patients with COVID-19 was quite small. There was no control group and no adjustment for potential confounders. Our group performed the COVAPID study to determine the relationship between VAP and SARS-CoV-2 infection. It was a European retrospective study performed in 36 centers, mainly in France, but also in Spain, Greece, Portugal, and Ireland. The patients were included in one of the three groups, a group with SARS-CoV-2 pneumonia, a group with influenza pneumonia, and a third group with no viral infection at ICU admission. The primary objective was to determine the relationship between SARS-CoV-2 infection as compared with influenza or no viral infection on the incidence of VAT or VAP. Secondary objectives were to determine the impact of SARS-CoV-2 infection on the microbiology and outcomes of these infections. The definition of VAT and VAP was based on clinical, radiological, and quantitative microbiology data. The cumulative incidence of first episodes of ventilator-associated lower respiratory tract infection was compared using fine and gray models with extubation and death as competing events. Here are the results, and as you can see, we included 1,576 patients receiving invasive mechanical ventilation for more than 48 hours. There were some differences between the three study groups. The severity scores were lower in the SARS-CoV-2 pneumonia group as compared to the two other groups. The percentage of patients with diabetes was higher in SARS-CoV-2 patients as compared to the two other groups, but the incidence of COPD and other comorbidities was lower in SARS-CoV-2 patients as compared to the two other groups. The percentage of patients with immunosuppression was lower in SARS-CoV-2 group as compared to the two other groups, as well as the percentage of patients with recent hospitalization or recent antibiotics. There were also some differences regarding the cause for ICU admission. There was less shock in SARS-CoV-2 patients and more ARDS. There were also some differences regarding the characteristics of patients during ICU stay. As you can see, the percentage of patients with corticosteroids was not different between SARS-CoV-2 and flu groups. However, the dose and the duration of this treatment were higher in SARS-CoV-2 pneumonia group compared to the other groups. The percentage of patients with prone positioning was also higher in SARS-CoV-2 patients as compared to the two other groups. Here are the results regarding the primary outcome. The incidence of ventilator-associated lower respiratory tract infection was significantly higher in SARS-CoV-2 group as compared to the two other groups. As you can see, 50.5% versus 30 and 25%. And this difference remained significant after adjustment for potential confounders at ICU admission, with a sub-hazard ratio of 1.6 for SARS-CoV-2 versus flu, and a sub-hazard ratio of 1.65 for SARS-CoV-2 versus no viral infection. Similar results were found in the subgroup of patients with VAP. What about the microorganisms responsible for VAT and VAP? Gram-negative bacteria were the most common in the three study groups, and the top three bugs were Pseudomonas, Enterobacter, and Klebsiella. Surprisingly, the percentage of patients with MDR was lower in the group with SARS-CoV-2 pneumonia as compared to the two other groups, 23% versus 38 and 34%. What about the impact of SARS-CoV-2 infection on the outcomes of VAP and VAT? As you can see here, the VAP was associated with significantly higher mortality rate in the group with SARS-CoV-2 pneumonia and also in the group with influenza. VAP was also associated with increased duration of mechanical ventilation in the group with SARS-CoV-2 pneumonia, but not in the two other groups. And VAP was associated with significantly longer duration in the ICU in the three study groups. There are several potential explanations for the higher incidence of VAP in SARS-CoV-2 patients. The first one is the prolonged duration of invasive mechanical ventilation. As you know, this is the main risk factor for VAP. It was identified by several studies in the past as the main risk factor. There is also the higher rate of ARDS and the higher doses and also duration of treatment with corticosteroids. And these factors are also well-known risk factors for VAP. Another potential explanation could be the specific pulmonary lesions related to SARS-CoV-2 infection. And this is an interesting study that showed that there was very specific histological lesions in patients with SARS-CoV-2 infection as compared to those with influenza. Mainly, there is severe endothelial injury with widespread thrombosis. So this could result in reduced local immunity and bacterial clearance, and why not higher colonization and infection rates. However, this is still a hypothesis that should be confirmed by further studies. To conclude, the incidence of ventilator-associated lower respiratory tract infection is higher in COVID-19 patients as compared with influenza or no viral infection patients. Gram-negative bacteria are the most common bugs in COVID-19 patients, and the top three bugs are Pseudomonas, Enterobacter, and Klebsiella. Further studies are required to better understand the pathophysiology of this infection and to improve prevention and outcomes. Thank you for your attention.